anatomical condition where you have compression of the particular anatomic structures as they exit the shoulder girdle, between the shoulder girdle and the first rib, okay? So what are we talking about? What's the shoulder girdle? That's the clavicle, okay? What's the rib? Well, that's the first rib, right? So I'm sorry, that's the rib front area? That's more of a question. So it's the first rib, correct? That's what we're talking about, okay? But you can have compression due to other ribs, and we'll talk about that here in a second, okay? So the thoracic outlet, is literally that anatomic landmark, that narrow space between the superior shoulder girdle and the first rib. Superior shoulder space, again, being the clavicle. Does that make sense? Everybody knows that the clavicle is the girdle between the axial skeleton and the peripheral skeleton, correct? So central versus peripheral. Okay, so that's what they mean by shoulder girdle, okay? TOS, as it's called, thoracic outlet syndrome, very common in women 20 to 50 years old, okay? And we will discuss here in a little bit how it can have a higher incidence during pregnancy. So again, that tends to fit that mold that we're talking about, okay? So, secondary to congenital abnormalities. So this is what I was talking about, that cervical rib at C7, okay? Is C7 supposed to have a rib? Who said yes? Nobody said yes, not even in your mind, right? Right, because the cervical vertebrae are not supposed to have a rib, okay? So that's an anatomical variant that can also cause compression. So do you think we're going to get x-rays for all these people that we're concerned about, all these patients we're concerned about that may have TOS? Absolutely 100%. That's what you're looking for. You're looking for congenital abnormalities. Congenital meaning they were born that way, okay? They didn't become that way, okay? But that is the most common. But you can also have an anatomic variant where you have a long transverse process of C7 as well. Okay, so I hope you guys understand the difference, right? So one is like literally a rib, and the other one's just an elongated transverse process. Okay, a little bit of a difference there. Okay, so you can also have an anomalous fibromuscular band. So why do we talk about fibromuscular? You see the heads of this muscle here, right? So you have two heads there. There's actually three heads in that muscle. Okay, but you have two heads there, and basically they can become fibrotic and scarred essentially, and they can cause compression of those vessels as they exit that narrow space there, okay? What artery is that? Subclavian, perfect. Somebody here has probably poked it, whether on purpose or on accident. Okay, what's the artery? Subclavian, okay. What's the nerve? You need to know this, right? Because then I'll tell you the distributions you're probably worried about. Okay, so I'll leave that open. Somebody else ought to Google it. But you should know this stuff, okay? Again, so you can have either bony compression, essentially, or you can have compression due to fibrosis of that musculature that we're discussing. Okay, makes sense? So do you think sometimes we'll get an MRI and look and see if there's any fibrosis? Absolutely. Maybe there's a tumor there. You can have a tumor there. We'll talk about that later on, okay? If you have a significantly displaced AC joint injury, and we talked about those, right? Type 4 and 6 being bad ones, okay? If they're significantly displaced, who knows where that thing's poking into, right? At the end of that clavicle. It's poking into this narrow space here where those vessels, right, nerves, musculature is running. Can that cause compression? Absolutely 100%. And again, there's a higher incidence in pregnancy. And that's due to a number of physiological reasons. But we do understand, and I'm not trying to get tomatoes thrown at me, but there is an increase in weight during pregnancy, okay? Some of it's the baby and some of it's not, right? But it can cause compression and displacement of certain anatomical structures, which can lead to compression. Good to go? All right, nobody threw anything, that's good. All right, neurologic symptoms, what are you gonna see? Diffuse non-specific complaints of the upper extremity. So these are the patients, again, they're gonna come in, they're gonna say, every once in a while when I'm doing certain activities, I feel like my fingers, I feel a little numbness and tingling in my fingers, and then again we talk about what? Vascular changes too, okay? That's at the bottom there. So they can have intermittent swelling and discoloration, and they can feel achy and weakness, okay? Achy just meaning like, they feel like they're sore in that area, essentially is what they're describing to you, okay? Getting back to the paresthesias can be, again, non-specific, but if they are in a specific distribution, ulnar nerve tends to be the most common one that we're concerned about, okay? Makes sense? Medial forearm and fingers, okay? That's where we're going to start talking about those nerve distributions, correct? Any questions about that? Okay. All right. So when we're talking about physical exam, we already kind of mentioned the Ruse test a little bit in some way, shape, or form, right? Because we were talking about some shoulder stuff. We were talking about some spine stuff last block, all right? But the Ruse test is basically the big thing to take away about the Ruse test. I know you guys already had that in Clint Skills? You have not? Okay, so on the first. We'll go through it Friday. I'll demonstrate it specifically again, okay? But basically the Ruse test, there's no one specific finding. It's not like you have a positive or negative finding. But sometimes you'll have only the vascular components, and sometimes you'll have only the neurological components. Oh, and by the way, depending on how long they do the Ruse test, they can go from one to the other, and vice versa, right? So it's important, again, to kind of take that into account and get a sense when you ask your patient to describe what they're feeling, where they feel it, when they feel it, right? It's 20 seconds into the test, 30 seconds into the test, a minute into the test, okay? So this test, though, the Ruse test specifically, it's actually supposed to be performed for about 3 minutes, right? So as you're doing the Ruse test, you're standing there, you're talking to them, right? Getting a better history finally. That's a joke, right? But you basically just have to kind of sit there and watch them go through this, right? Doing good dad jokes, et cetera, et cetera. But just basically, you need to take a mental note of when they experience these symptoms. You think when people get into a Ruse position, right? That's that 90-90 position. I surrender, I give up, right? Then if they have symptoms, they come about quickly, like let's say with it less than 15 seconds, that's potentially an indication of more serious pathology. Pause to let you answer. Yes. Okay. And again, there are some modifications to the Ruse test where you can actually take their shoulder and elevate their hands up into the sky, like I really surrender now, right? And it worsens their symptoms too, because you're causing further compression. Okay? When we're talking about compression, we're talking about this compression in this space, this narrow space, right? Yes, that's what we're talking about. Okay? So this is not talking about cervical nerve roots. So again, go back and start laying things out and figuring out where this pathology lives, essentially. Okay? Where this pathology is present. Don't get it confused, again, with plexopathies and or with cervical nerve root issues, otherwise known as cervical radiculopathy. Okay? Good to go? So the AdSense test, I'm not really sure why it's not taught. It's not in your book, believe it or not, in your physical exam book, which is strange. But did you guys cover AdSense test in the, no, okay, good. Thank you, I appreciate your honesty. And even if you did, you say no, so I get it. Yeah, but when you're talking about the AdSense test, basically it is a test where you put the patient into this position, right? So which side do you think that the pathology is on in this, since the patient is facing right? The right side, right? So you have them lean their heads towards the right, you palpate the radial pulse, and you feel for a difference between the left and the right side of radial pulse. Didn't we already talk about how there's blood vessels that run through that narrow space between the superior shoulder girdle and the first rib? Yes, so that's potentially a compression there. So again, the AdSense test can actually help you differentiate if you kind of have that mixed clinical picture with the Ruse test. Then you do the AdSense test, and you're leaning more towards the vascular component of it, correct? Okay, because again, you're compressing the blood flow, and therefore the pulse, and you're feeling for that pulse. We will go through that in the lab, I promise. Okay? We all tracking so far? Okay? And which nerve is the most important? Ulnar nerve, and that'll come into play. Okay? More specifically, because we'll start talking about some compression syndromes, and then we want to make sure we keep all that straight in our head. Okay? Any questions about this so far? Yes, sir.
So the AdSense test, you're trying to induce compression to confirm that side.
Correct. More of a vascular. So AdSense is more of a vascular test. Ruse test can be kind of a mixed clinical picture. So his question was, are you trying to induce vascular compression? Is that what you said? That's what I heard. And the answer is yes. Okay? Well, can the AdSense test, will they say that they have more neurologic dysfunction? Sure, but what are you palpating for? The pulse, right? So this is a very I don't want to say specificity, right, or sensitivity, because then you guys go into the tilt. But I'm just saying, it's more specific on what you're looking for. Does that make sense? Okay. I know it's hot. All right. Ruse test. I give up. And again, a ruse test, you can do it for the open, closed hands. Right? So ruse test is important to understand. When you're opening and closing your hands, it's not a hello, Captain Carbiner. It's basically fingers and thumb. Okay, so it's like they're trying to grab a baseball, right? Let go of a baseball, grab a baseball, let go of a baseball. Okay, so that's the motion, not this hi, hello, right? I mean, yeah, that's not what you're doing. Because you're trying to get them to give you a maximal vigorous effort, right? So you can really get to it and see if this is a positive test. The reason you have, a lot of times I've seen people have equivocal tests is because, again, they're doing the hey, hello test, and where they're kind of doing, and their arms are not at 90-90, they're still down here. You got to be arms up, I surrender position, open and closing, like you're trying to grasp vigorously, right? And you tell the patient, hey, turn on. You tell the patient, hey, let me know what you feel, where you feel it, and when you feel it. And again, you'll be looking at the clock and trying to count down. Okay, make sense? So I think we beat that to death a little bit, but we'll go through it on Friday. Just trying to make sure you guys are ready for that. Okay? All right? Good. Bruce test is in your book. Thoracic outlet syndrome. So the radiographs you're going to get, again, you're going to get those radiographs looking for those anatomical variants. You will get this regardless of whether they have any breathing issues, whether they have any radiculopathy issues. If you even think it might be TOS, this is literally part of the workup. You miss this component of it, you might miss the underlying diagnosis. Or the causative pathology, meaning this is what's causing it. It's that anomalous C7 rib versus that long transverse process, right, versus something else. Okay? Makes sense? So this is part of the workup. Okay? So the lungs is the apical component of the apices of the lungs. Are they kind of up near the clavicle? Yes. So can you have a you guys know about Pancoast tumors yet? Yes. So this is why you guys know. This is why you get a chest x-ray too. That's part of the workup. You don't want to miss lung tumor or infection. Okay? MRI of C-spine. Okay? If there's any symptoms whatsoever, again, with that kind of a mix. Bless you. Oh, you said it. Okay. I missed it. All right. Thank you, sir. You're welcome. So when we're talking about that mixed clinical picture, then you're trying to discern whether or not the TOS is from that anomaly compressing that narrow space between the superior shoulder girdle and the rib, right, the first rib, versus radiculopathy, so more nerve root compression. What's that view you look at again to see if there's compression of the nerve root as it exits the foramen? Which view on an MRI? Axial cut? Okay, good. So you're going to try to zoom in on that, okay? Spondylosis, we know what that is, right? That's just degenerative disc disease of the cervical spine. It doesn't really tell you much. You can have those osteophytes, you can have that narrowing, but what is all those findings, what are they causing? How could they be contributing? Make sense? So, we get back to it. I keep harping on this. But if there's a mixed clinical picture, which, by the way, they're very common in this with TOS. TOS is a tough diagnosis for a lot of times because it kind of lives in a bunch of different pockets, right? So if there's a question as to whether it's radiculopathy, compression at that narrow space between the superior shoulder girdle and the first rib, versus peripheral neuropathy, right, due to other disease processes, versus ulnar nerve entrapment at the elbow, which we're going to talk about eventually, here shortly, then what's that study we get? EMG nerve conduction study. I hope in your clinical practice, guys, you never miss that. Because guess what? Can that help you kind of alleviate some of your frustrations about their clinical picture, about your physical exam findings? It really can. Right? So this is only meant to, again, strengthen you in your diagnostic skills. Okay? This is not an uncommon study that we get. Okay? Does everybody see the difference between the cervical rib and that long process there? These pictures with the arrows? That's all that's showing you. Okay, these are some representations I added, right? See the check mark, check mark? You shouldn't have a rib up there, right? That's C7. There should be no rib. Okay? And then down here, you have that long transverse process. So again, this is that anomalous rib And now down here, this is more of a long transverse process. Is the terminology sometimes used interchangeably? They just say, well, you have a cervical rib at C7. Not uncommon, but it's important, if you're going to diagnose somebody, to be factual. Okay? That sandwich looks good. Thank you for eating that while I lecture. I'm joking. All right, so basically, if you're going thoracic outlet syndrome, do you think, and just think about this for a second, if their symptoms are bad enough, if the rib is compressing long enough, or if a tumor is compressing long enough, by the way, do tumors grow? Yes, so whatever's causing the thoracic outlet syndrome, right? And I think syndrome, anytime you hear the word syndrome, that means you have a constellation of symptoms. And that fits this nicely, right? Because it's a constellation of symptoms sometimes. But do you think that the longer it's present, the more significant your pathology is going to be? Yes, right? So they may have weakness and loss of coordination in the upper extremity. So they're no longer able at times. Remember, I told you guys some tricks already, and we'll talk about this more when we talk about hand fractures or hand entrapments, right? Elbow versus hand, wrist entrapment of nerves. You ask them, are you having trouble turning doorknobs? Are you having difficulty grasping small items? Are you having difficulty, with fine motor activity? We know what we mean by fine motor activity, right? Things like typing. Say somebody likes to build, origami, right? I was talking about Japan, right? So keep thinking about it. So origami, and now they're having difficulty with that fine manipulation of the fingers. Yes, so that's going to be, these are strong clinical indicators that maybe this is more progressive or long-standing pathology, okay? Chronic headaches, okay? Do you think if people have compression and swelling and in or around the neck that it can cause reciprocal spasm, okay? Yes, and we already talked about how sometimes that spasm, that upper trapezius spasm or the paraspinal spasm, right, can cause headaches. Those are linked. Okay, so again, we're making that clinical picture of a syndrome. And loss of overhead range of motion. Do you think that they're going to complain about going overhead, right? So they're going to stop doing it? Do you think they can have stiffness that kind of results in some loss of motion itself? Absolutely 100%. So, but they will tell you that they are unable to reach overhead or put items at home. They're unable to put items into the top shelf, right, because of these symptoms. And some of it, again, don't fall for this trick, right? Don't fall for that sandpit that exists where you say they're unable to do it. So is it that they're unable to do it because that's weakness, right? Or is it that they don't want to do it because it causes pain, right? So I just cut down on 50% of your consults probably, if you understand the difference between pain-limited range of motion and weakness-limited range of motion. Okay? I hope you guys remember that. Don't worry, you'll be reminded of it in phase 2. Because ortho, it's like pain. Well, yeah, they got pain, but do they have weakness? Right? That's an important qualifier. Okay? Non-operative treatment, that's the mainstay, that's the gamut, right? Everything we always talk about. NSAIDs, rice, activity modification. Do you go sticking needles in or around that area there? Heck no, don't be that person, okay? Don't do that. So it's very conservative care. And avoidance of carrying heavy objects, placing straps over their affected shoulders, overhead activities, strenuous repetitive activities, and sleeping on that side, okay? So if somebody is an infantryman and that you are an infantrywoman, okay, different service, they're trying different things out, good for them. Okay, so when they come in, right, if they tell you that their job, right, it's an important qualifier, do you think you have to give them a restriction of that backpack wear? Sure, right? Do you think they're going to get that restriction honored by their unit? Probably not. Right? So sometimes you got to pull them from whatever it is they got going on and put them into dedicated supervised physical therapy because that's the only real way you're going to see if there's any improvement. Okay? Proper posture, it says, and weight loss. Obviously, if there's preponderance of tissue in that area, that's the way I'll say it. Right? Can it cause further compression? Absolutely 100%. If somebody stoops and slumps, right? We already talked about that hyperkyphosis and how we don't want to see that. So take a look at the full picture of the patient, right? Are you going to have them stand up in front of you while they're doing the ruse test, not wearing a shirt? Yes, because you want to see those vascular changes, right? Right? You're looking for those changes just in the fingers. I think that's what you guys are kind of taught to look for. But you can have vascular changes throughout. Okay? And you can have swelling throughout too. We already mentioned that. Okay? So shirt off. So you think you can see how they stand? And you can kind of look from the back and see what the curvature of their spine is. All those things you guys already know, right? So you got to make sure you don't miss the bigger picture because you're not looking for the finer details. Okay? Good to go? Any questions about anything I said so far? Okay. Have you guys been introduced to TENS yet? Transcutaneous electric nerve stimulation? No? Okay. So personally or professionally? Personally, okay. So when you went in, did they put pads in strategic areas to cause nerve stimulation? So that's all they're doing. Trying to stimulate the nerves in that area, trying to get a response, right? And trying to alleviate some of that symptomology that they may be describing. It's a little bit more to it than that. But just understand, TENS is not an EMG nerve conduction study. They are two different things. One is diagnostic, that being the EMG nerve conduction study. I agree it's hot, right? And the other one being therapeutic, which is TENS. Make sense? There's no diagnostic per se component to TENS normally, okay? But it can help decrease the severity of symptoms. You guys understand that stimulation and overstimulation can cause people to perceive pain, right? So if you try to drown out some of that overstimulation by, and this sounds counterintuitive, right? By you introducing certain proper and positive stimulation, that's the technique we're talking about, okay? Is that something you guys are going to be doing? No. That's physical therapy, that's the rehab world. Some pain management and rehab, PM&R. Have you guys been introduced to what PM&R is yet? Physical medicine and rehab. Okay, those are the guys that do a lot of pain stuff. They do a lot of therapy stuff, therapeutic injections, stuff like that. So they have some bleed over into certain areas. But what they are not is surgical. Okay, so operative. What does it say there? Remove a variant, right? So can you go in there and whack that anomalous rib, that anomalous transverse process? Absolutely, 100%. If God put it there, I can remove it. Right? But having said that, you got to make sure you know what you're doing. Okay? Because if you don't, you start mucking them up in around there, right? Can badness occur? Yes. That is not challenge accepted, by the way. I commonly tell my patients, we can do surgery, but the question becomes, what is the right surgery? Does that make sense? That's actually my stance, okay? That was just for comedic effect. Okay, but this is normally going to be neurosurgery. I don't even know if I've seen ortho spine do it. I've never scrubbed this case. So, but neurosurgery, they live in and around the brachial plexus, nerve roots, stuff like that. Can a spine ortho guy do it? Sure. I've just never seen it. Okay, but do you think they go right to surgery? No. Okay, that's not the case. Especially with TOS, very common. Like I keep telling you guys. This will be one of those things where you're sitting in clinic at the end of the day, you got all this imaging, you got your physical exam, and you're just like, I don't know. This is like a mixed clinical picture. Pretty sure it's TOS, but is there a component of radiculopathy? So again, like I'm getting at, there will be a lot of non-operative care that occurs. And it may be multidisciplinary, right? They go through multiple rounds of physical therapy. Is anybody here a physical therapist? Physical therapy tech? Anything in the rehab world? Someone's a liar. Oh, yes, sir. All right, so you know that like not every therapy person's the same, right? All right, so I was an exercise physiologist. I consider myself to be sort of a rehab guy, but I am not a physical therapist. I just tell people what exercises to do, but I don't guide them through the exercises. And same thing with physical therapists. They actually have different specialties. Believe it or not, they have a specialty in ortho, which is confusing, right? But they get more in-depth ortho training. But they also have a specialty in neuro, which makes sense, right? So inpatient neurologic, and also with pediatrics, okay? Trust me, this will come to bear when we talk about different therapy stuff later, okay? Not wasting time, okay? So adverse outcomes of treatment, so you do things to people, right? I do things to people, what can happen? We already talked about how when people have surgery, Crips lives sometimes in the post-surgical world, right? So you got to ask them those questions. Do you have a previous history of surgery, right? And to include the one we did, right? We know we did it, but maybe the patient's new onset pain. And remember how crypts is a little bit different, right? Crypts is like that burning, searing pain, correct? And it may be present whether they're lifting their arms up or not. It can be that I walk up to this gentleman here and I lightly, and appropriately by the way, brush his shoulder, right? And he's like, oh my God, 50 out of 10 pain, right? Like that's that hyperesthesia, that's that decreased sensitivity. So again, this could be post-operatively. They can start having more significant symptoms, okay? Make sense? You okay, sir? All right. I didn't hurt him. Frozen shoulder, we talked about decreased range of motion, so I hope somebody in this room, or all of you actually, I hope, were like, wait, decreased range of motion? So that means they could get frozen shoulder. We already talked about that. So they can live together, okay? So again, multidisciplinary, multidisciplinary. Brachial plexus injuries, all right, there we go. So when we talk about brachial plexus injuries, I already talked about how brachial plexus injuries, that's C5 to T1, correct? This is further away from the brachial plexus, okay? Would you agree? Because now it has gone down and dipped underneath into that narrow space between the superior shoulder girdle and that first rib, right? But in treating this, can you cause some brachial plexopathy? That's what they're getting at here, okay? So distance those away. This is talking about adverse outcomes of treatment, okay? And pneumothorax. I just told you how the APCs of the lungs live in that superior orientation, close to that space that we're talking about. So if people go in there, start cutting through, mucking around there, can they cause a pneumothorax? Absolutely. Okay? All right. So red flags, neurovascular changes. Any patient that you suspect has long-standing or increasing neurovascular changes, you would refer. Okay? You would refer. Okay? Anatomic variance with symptoms. I will tell you this. Sometimes you guys will get cervical x-rays, right? And you will look because you're concerned about radiculopathy. And you're like, this is radiculopathy. The distributions, those dermatomal, myotomal distributions are present. They don't have all that other symptomology that we talked about with TOS, right? So, but then you get the x-rays because you're an astute clinician and you see the rib, right? So have you guys been introduced to the term incidental oma yet? Right, somebody in here knows what that is. Right, but sometimes you'll find things because you're looking for other things, right? What is important for you guys to understand is that causing anything here? Or do you need to, you're like, oh, I found a cervical rib, so I need to send them. If they're not having TOS-specific symptoms, you still treat them as cervical radiculopathy if you got it nailed down. Make sense? So red flags, I would say this is the red flag, right? You're doing things, you're doing things. And again, the patient just keeps getting worse. By the way, if you do that Addison's test and they lose a pulse, that's not good, right? Like you're supposed to have a decrease in pulse, but not supposed to lose the pulse, okay? Because that means that you need to be more suspicious about a big old tumor that's living in that area that's causing some significant space occupying mass type symptoms. Pancoast tumor, anybody? Right? Ooh. Weight loss, right? Fevers of unknown origin. Good. You gotta start getting some advanced imaging and work this up. Okay, so again, that goes in that red flag area. Okay? Right. Any questions? All right. I've taught this so many times at the national level that I hope you guys are getting the high points. Okay? This is a topic I don't very commonly teach, but I teach it here, right? Neonatal brachial plexus. Palsy. Okay? This is a palsy. Okay? So with most terms, you guys know about certain palsies, right? What palsies do you guys know about so far?
Bell's palsy.
What is it?
Bell's palsy.
Bell's palsy. Okay. So you know that in Bell's palsy, you're hoping that the symptoms resolve, correct? Right? So you're hoping it's not long term, but it can be. Okay? But the rule for Bell's palsy is a patient regains at least a certain high percentage of normal function, correct? That's what you guys learned, right? Right? So that principle still applies here. And neonatal, does that mean that they're babies less than, usually typically about 4 months old when their diagnosis is made? Yes. Okay? Notice I haven't gone to the slides yet. That scares people. But I will tell you that if a patient I used to do medical missions to the Philippines, right? Do you think that those in some parts of the world, right, that patients don't get regular routine medical care? I'm not big on the Philippines. I love the Philippines. Salamat po, right? So when you're talking about this, right, you want to again get a history of their routine medical care and their immunization status, correct? I hope infectious diseases scared you to ask to ask immunization status on every freaking patient, right? I hope they have scared you. I hope infectious diseases scared you to ask them, have you had any recent worldwide travel, right? If they're military, have you been stationed overseas? Have you ever been stationed overseas, right? Do some viruses lay dormant? 100%, right? But I digress. Okay, brachial plexus, what's the most common? 50%. I changed this slide, allegedly, and put that in bold gold, right? Why? Is it important to understand that if you're going to spend your time studying and that if there's going to be a test on pants, it's probably going to be about Erb's palsy? The answer is yes on all counts, okay? So, now, important to understand, I'm going to tell you about a position. It's called the waiter tip position. I'll save my little description or demonstration, if you will. But what we're talking about here is weakness of these things, right? So they're going to have weakness of elbow flexion, shoulder abduction, flexion, and external rotation, okay? That's what they're going to have weakness in. So that's going to result in a certain presentation and a certain positioning or posturing of the patient. In this case, a neonatal patient, correct? When you go to examine them, or when the parents bring them in and they get them trauma naked, take the diaper off too, right? And all that stuff, okay? What's Erb's palsy? What's 2 levels are we worried about? C5, C6, okay? And true or false, Erb's palsy, right? It's on the board. Is the most common.
True.
It's true, right? So you should know this, okay? I can't harp on it enough how much I will bet you, right? I'm not a betting man per se. No, that's a lie. But I would tell you that there's a high likelihood you'll see a question about this, okay? And then the other one they like to throw you off with is this clunky palsy, okay? I don't speak that language, so I think I'm saying it right, but clunky, right? Not Professor Clunky, okay? So this is the one that they tend to kind of throw it in there and confuse you. But just understand that's only about 30% of the cases, right? So, and that affects the hand and the wrist primarily. Is there any loss of shoulder or elbow? Is there any weakness in that distribution or in those joints? Not normally. So this can be more of an isolated hand and wrist weakness, okay? And then panplexus, right? We understand that pan meaning throughout, pervasive, right? So meaning a plexus, right? That's only 20% of the cases. And again, that involves the entire plexus. Okay, so if you're going to focus your time, it's on that 50, 30, right? That's 80. Nobody likes to do math in public. And then the last 20, right, is just all throughout. So this panplexus palsy, all right, let's get back to what kind of causes this, right? This is neonatal brachial plexus. Right? So what causes that compression or that stretch, like we talked about before, but this being different because it's neonates, it's some kind of traumatic force, correct? So this is the trauma of being born. It causes this, okay? The traumatic experience of being born. But having said that, sometimes you have to ask the patient. In fact, I would tell you must ask the patient, right? Well, the patient's parents, because the patient won't tell you anything. Right? For the patient's parents, was this a normal vaginal delivery? You guys haven't had women's health yet. They'll scare you into asking every female, when you ask them their history, say, describe your history to me. How many how many C-sections? How many normal vaginal deliveries? If they tell you it was a complicated delivery, do they use certain instruments to try to pull the baby out? Yes, they do. They can use a big salad tosser looking thing, right? They can use suction, okay? But I will tell you too, that if you want the baby, I think you guys know this, right? Everybody's watched videos, everybody's had sex ed in school, right? The baby normally comes out head first. right? Well, what if they don't? Then you gotta get them out, right? And you gotta get them out quick before you have two bad outcomes, right? So heroic maneuvers can be undertaken. So again, not to go down that road, you guys will have women's health. But if you hear a complicated delivery on a pants question, or let's say next Friday, right? You should be tuned into the fact that, oh, I bet you this is Herb's palsy, okay? Is that the most common, 50%? Is that the one that has the best prognosis, 100%? Is it associated with a, not straightforward? Let's say the term uncomplicated delivery is not used. Yes. Okay. Makes sense. Okay. Poor prognosis factors. You guys already know this, right? If the entire plexus is involved, that's not good. If it's preganglionic versus postganglionic, that's not good, right? Remember that when we discussed this about brachial plexopathy in adults, right? Horner syndrome, halitosis, right? You guys know about Horner syndrome, correct? Yeah. Meiosis, ptosis, right? And hydrosis. Is there a slide? No, that's assumed knowledge at this point, that you guys know that. If you don't know what Horner syndrome is, look it up, right? Get refreshed with it. If you have questions about it, I'd be happy to go through it. I'm just saying that's all those other factors that could be involved too. But if that's also present, there's a worse prognosis, okay? Everybody understands this picture is getting to the brachial plexus, right? Okay? Brachial plexus there? Okay. All right. Here we go. All right. Reduce spontaneous movements, what you're going to see. And you're going to see the patients in this posture, okay? And the parents are going to tell you there was a complicated delivery, and they noticed in the post-delivery assessment that this posture was present, okay? It has continued to be present for the last few months, okay? So this is what they call the waiter tip position, okay? This is probably outdated, but if you were to walk up to, don't get nervous, sir. I'm just demonstrating. All right, walk up to somebody and say, "Give me a tip." You give me a. You didn't actually give it to me though. That's fine. But you say you're just trying to sneakily get a tip, right, or a grape, which you didn't give me, right? That's what they mean by the waiter tip, right? You're kind of trying to sneak in a little tip. Okay, that's what we're talking about with waiter tip. Doesn't really translate to today, right? You have like my grandmother probably, oh, waiter tip, I remember that. We used to tip on the sly, if you will. Right, but that's what they're talking about, okay? But you would agree that the patient, if they're sitting there in this position, or this posturing, right? I still want my grape later. Then you're going to have decreased motion, right? So paralysis means that they can't move, right? So we use this term pseudo-paralysis, okay? Because you're hoping it's going to return, right? That their motion is going to return, okay? So pseudo-paralysis. Don't get all that terminology confused, okay? When we get to test for you, let me know. Discomfort, irritability, good luck picking out the differences in that, right? All kids cry, right? So some IPAP students cry. I mean, patients cry, right? So, but irritability, what is that? That means when you're trying to do range of motion, you're trying to do an exam in that area, they may cry more, right? That's irritability. All right, sometimes when there's that traumatic delivery, or sometimes when it's just a delivery, right? Can you fracture the clavicle? 100%, okay? You can. Okay, and if it's just a clavicle fracture and we think that palsy is due to that, will the clavicle fracture heal in a 2 or 3 month old pretty quick? 100%. At that age, we say, if both ends of the clavicle are in the same room, we don't have any problems here. All right? I know that sounds flippant, but that's what we say. Okay? When you call me on the phone and say, I got an 8-year-old with a clavicle fracture, it's kind of the same principle. Like, are both bones in the same room and not sticking out of the skin? Yes? You're going to be fine. All right? Sling. All right? But anyways, we'll get into that later. Humerus fractures, obviously if you have a humerus fracture, that was probably a pretty significant delivery, right? All right? So humerus fractures, there's a whole direction we can head to with that. All right, but just understand that those two things can exist as well. Okay? Any questions about that? All right, herbs, waiter's tip position. Okay? So what is occurring there? This is not the weakness, this is the position. The shoulder is adducted and internally rotated. The elbow is extended, not flexed, right? Forearm is pronated, and the wrist is flexed. Everybody see that in that picture? Take a moment to look at it and convince yourself that you see every single one of those, that appearance there. All right, in that picture I added, allegedly, to give you guys a better indication of what we're talking about. I even gave you the bold gold arrow. Okay? So that's the waiter tip position. So you're trying to come up, you're trying to get a break. Right? You're doing this. Oh, he tried that too. But that's what they're talking about, right? So just think about that position. So if I see a student, right? If I see O.C. Thapa, she's doing this during the exam, I'm like, yes, right? She's doing what I told you to do day one. Your body is your best example you can do. So put yourself in the waiter tip position. Don't do it with this gentleman. He won't give you a break, first of all. But that's just awkward during the test. Okay? So what's worse, pre or post? Pre-ganglionic. I'm glad that you guys knew what I was talking about there, because I think you get complete sentence. Yeah, I need to take a break too. So, repeat exam. So if you have neurologic deficits, you have weaknesses, you think you're going to do repeat exams? Yes, serial exams over a long period of time, over a few months, right? Because like I told you before, Erb's palsy has the best prognosis, okay? And therefore should improve. How are you going to be able to not just document the improvement, right? But actually see the improvement is by doing these exams over and over and over to see a return, okay? Now, slowly over time, you notice that pseudoparalysis starts to improve, and now you actually have spontaneous movement at the extremity, okay? And you're like, okay, we're heading in the right direction. Do you think the parents are going to be freaked out when they come to your clinic? 100%. You might have 3 patients that day, okay? Hopefully none of them passes out, but I'm just telling you, one of the most important things you guys have to understand about medicine, guys, is that when you are talking about pediatrics, you're talking about parents, they freak out. You need to do reassurance and education, right? You can document that. You get more CEUs too, but that's another story, okay? But make sure you're doing it. Don't just walk in here and say, yes, Mr. Bishop, it looks like your kid has Erb's palsy. It should improve. Yeah. All right. And you're just like an next, right? You move on to looking into other areas of the body, right? Spend some time with it. Do education. Okay? You're documented. Please be doing it. Plus, parents freak out. Don't worry. You'll get messages on Genesis. Everybody understands that Genesis has the ability. You have like the chat room. You can almost, right? Patients can message you 24/7, and some do. That's why I have my nurse check it. Okay. I don't have access to that. Don't learn bad habits. All right, so diagnostics, radiographs, again, I would tell you, do you guys familiar with the term babygram? No? No? So babies are pretty small, right? You guys have seen an x-ray plate, I hope. I've shown you a couple of examples in multiple slides, okay? You can put the whole baby on the plate, right? Well, guess what a babygram is? You have the entire baby on one plate, okay? And you can see a lot of different things. So if you have a suspicion for a clavicle fracture, you can get more focused shoulder radiographs. But again, a lot of times a babygram is done if there was a traumatic delivery, just to look for fractures. Can babies also get rib fractures from traumatic deliveries? 100%. So again, I'm just teaching you stuff that's more associated with Erb's palsy, or I would just say with neonatal brachial plexopathy, right? But that can exist as well, okay? So what are those little electrodes that are attached to the baby there? Do you think those are the electrodes that might be used in a nerve conduction study? Yes. So how are you going to objectively be able to assess and document that you're seeing improvement in nerve conduction? I heard you're going to do an electromyography with nerve conduction studies, because that's literally in the title. Okay? Are the muscles working? Are the signals getting there? And how fast do they get there? If you have a decrease in that latency, you guys read the highlighted reading, right? When it came to nerve conduction studies, and you understand that you're looking for decreased latencies or increased latencies. Okay? That's a delay in that signal. Some north and south, some whatever. It's hot. I get it. Make sure you're looking at that. Okay? That's all that's saying there. Okay? So physical therapy, like I was alluding to earlier, is physical therapy going to be challenging for neonates? 100%. Is there a subset of physical therapists that are specialized in pediatrics? 100%, right? So again, don't just send them to physical, don't send them to that person that sees trainees and recruits, right? Because they're gonna be like, oh, this got sent to the wrong place. And then it's gonna take another 6 to 8 weeks. Don't get angry, Mr. Wood. Okay? Yes, there's sometimes a delay in care if you don't send them to the right place. Okay? All right. So microsurgical reconstruction, okay? The brachial plexus, is that anywhere I operate around?
Nope.
I already told you no, right? But when it comes to neonates, you take an already small and make it super small, right? So there's a lot more to it, okay? Surgery to address imbalance of the upper extremity. All they mean by that, I'll give you guys a little taste of what they're talking about, then we'll take a break, okay? All they mean by that is if you have muscular imbalances, right? Say you have contractures. You guys know what a contracture is. Something's been stuck in a position long enough and not moving. Say the arm's been an extension, now they can't flex it. Do you think they can get contractures? Yes. And so therefore, the contractures, we talked about this when we talked about frozen shoulder. If patients get contractures, sometimes we have to go in there and release them. Okay? Different ways we do that. Okay? So that's all they're talking about there, is a little taste. Okay, so referrals, appropriate shortly after birth. It is not something you're going to sit on. You see a patient that's been discharged from a hospital, right? You're seeing them for like their first well baby check, right? And you document this, you need to refer it. That's what I'm getting at. Are you going to manage this? No, I would not. Okay? Now, if you're competent, great. If you're in a rural area, right? So you guys retire, right? And don't do what I do, just hang on for dear life on active duty, right? Or you guard gold diggers, right? When you get out there in the community and you're working in certain rural areas, the pay is great, right? But you become you got to hold on to things a little bit more. You can't just send everything to the big city, right? Because it's like a 4-hour drive, right? So you decide what your comfort level is. But I would say initially, you refer most of them, okay? Sepsis or skeletal trauma. We know what we mean by skeletal trauma. I put in parentheses. Sometimes you'll see the word, when you guys go to ER, you say concern for NAT, non-accidental trauma. That's a polite way of saying somebody did bad things. Okay? Does that exist? It does. So look for it. Okay? All right? Sepsis, that's bad, right? Infection's bad. Okay. So let's take a break.
Yeah. I might have an answer.
What she said about you free Ortho? All of these thoughts, I really highlight the chronology.
Yeah, I think it's more about the usage, so chronic pain usage, and also the use of opioid.
She wants to know the different brand names.
No,
What formulation it comes in.
no, I wouldn't stick specifically on that. No, because at the end of the day, they give us those brand names and generic. So like, if you see buprenorphine, you know. In this end, just know: am I using it for pain, or am I using it for withdrawal disorder? Well, good for you. I mean, it's good for you early on. I don't know. I got to talk to this, so I just got to figure out what it
I'm good. Andy, you got it.
You came up with the idea.
You're ready.
No, that's a great idea. I think you should push that up. We're gonna kill box.
Should we just maybe talk to him?
We should like tell him that the contest is I'm not taking that out.
But he's not. I'm sure he would let us know. So hopefully everyone's really stressed about this one. I'm sure he would.
Yeah, if we meet, just tell him, like, hey, we all feel pretty good about this. That's if he shows up.
Oh, that's
He came back. He came late. Oh, that Thursday when everyone was here, we didn't was here because last time when we went to seven.
Oh, yeah.
Oh, still being
It's like
So in the sense, it's the same.
like cars versus what? Okay, yes.
Yeah, that's true.
So if it's high dose, we're gonna call it.
Yeah.
High dose. It's not gonna be enough, right? So like if I can wait for it to wash out, then. And then.
Yeah. So it's the balancing of pain
There's 2 holiday blocks, and then random day in the middle, Monday. Monday, Saturday, Wednesday off. Here's why we're not getting. So we just random Wednesday and then this Monday. Right, Tuesday, Friday. And then we have that Monday. That's the last Monday day off test we'll have for the rest of the semester. You just have to turn in your final draft. It's optional. It's definitely not optional. What a crazy thing to say.
This makes this.
100%. Dude, it is crazy the variance between the people. Like I turned mine in and I got a little bit of feedback on mine. The paper's good, but you should make these changes. 100%. Oh, of course. But then Chloe got this in, and you're like 7-6 away. So like some people, I'm sure some did. Like you turned in 76.
That's when the entire paper got 77.
Others I said because if you look at the grade rubric, someone has like just because you got failed.
What? What? No.
There's just no standard. It's just
We didn't even wake you up. What do you think? Quarter after?
It's the guy that could move that shit like 70 times.
Right. We'll let people trickle in. Oh my goodness. What do you guys have after lunch?
More.
What's that?
Whatever you buy us.
I do.
Have after.
No, I thought he was going to buy us lunch.
No, you have me before lunch.
I think it's ID and then Indo.
Nobody knows? You know you're currently before lunch, right?
ID and Endo. I got it on my little sheet.
No, he knows where he is. Alright. Oh, an endo? Alright, but is that your first endo lecture? Oh, yes, right, okay, so you guys are still pretty fresh to it. Got it. Alright. Alright, so let's just keep going, right? So, when we're talking about that, I just want to gloss over this. When it says here that you want to check the status of the patient and their motion, it does kind of mention there, and we'll talk about this again later, when it comes to neonatal conditions, if they were otherwise normal following birth and something has changed, that could be an indication that there could be one of those hand plexus or something else, right? So that's a referral, 100%. Makes sense? You don't sit there and play and stick around with those. If all of a sudden, if they were moving fine, you know for a fact, You know, in Genesis, do you have access to the military, to the, medical records if they were seen in an MTF? The answer is yes. At least in theory you should, right? So you look back and you see the assessment that was done within 24 hours by a pediatrician only says that everything was normal, and now you have something abnormal at 2 weeks post-birth, right? So 2 weeks out of the box, right? Then that's concerning. You need to act, okay? So do you have the ability to look at who the treating pediatrician was at the time? 100%. Might you pick up the phone and call that person? Yes, because you guys are not going to be afraid to call people on the phone and have difficult conversations. Okay? Good to go. Torticollis. All right, torticollis. So this is getting into spasm, okay? But this is getting into different kinds of spasms, okay? There is a classification of torticollis, which your book doesn't really go into, but it's called spasmodic torticollis, okay? It's literally, that's what it's called. And that's one of the bottom ones, which is acquired, okay? Spasmodic torticollis is probably what you've seen in TV shows, right? Somebody takes a certain medication and all of a sudden they get lock neck, right? Or somebody strains their neck and they have a spasm and they're unable, they kind of walk around like this. That's spasmodic torticollis. What we're going to focus more on here, right, is lateral bending of the head to one side or rotation to the other side. So this is congenital, right? At the bottom it says there, congenital muscular torticollis. So this is something, again, is there going to be a history of being born in the last few months? Absolutely, right? So again, congenital muscular torticollis, not spasmodic torticollis, which tends to be more a term that's used more so in adults, okay? So, bending left, looking right. Everybody see that picture there? You see that bulge there, that muscle there, this SCM, sternocleidomastoid, right? How it looks like there's increased bulk there. There's contraction of that muscle. It doesn't want to relax. But their head is bending to the left, right? So tilting to the left, if not turning, right? And where are they looking? The opposite direction, okay? So that is your typical appearance of CMT, congenital muscular torticollis. So that's a category, okay? So again, it's not both sides, it's unilateral contraction of the sternocleidomastoid, okay? And I give you an example. If it's the other side, flip the verbiage, right? So in this example, it would be bending right, looking left, right? So it depends on where the spasm is. But you would agree that that contracted muscle, right, is it on the same side as they're looking? No, it's the opposite side. So that's one thing to take away from this because you'll get into the red flags later on. And that's what they're getting at there. So if you see an atypical presentation and it's around birth, right, or just in young neonates, right, you need to be concerned about that presentation because it may denote other things. The other things we're talking about is acquired. That's a whole other category. Acquired. Now, the problem with acquired is I could lecture on acquired for the rest of your time in IPAP and still not give it to you. Right? Still not give you all the knowledge you need to know about it. Okay? Because there's so much going on. Okay? But acquired, typically, we talk about acquired later in infancy or in childhood. Okay? Later in infancy or in childhood. Okay? Eyes, you can see some eye abnormalities. Okay? Can you tell a child to look at you and follow your finger? You can. They're not going to do it, right? So you do little tricks. Like you have a light, right? Or a toy, right? You have, start picking on other people. Well, let's say this Shaw over there, right? She has her favorite toy that she likes to hang on her stethoscope. So you might use that toy to get the patient to track that motion, okay? And we do know, right, that nystagmus is you get a certain amount of beats, right? And then anything over those beats, that motion of the eye is abnormal, correct? The answer is yes. Then you guys will go through that in neurology some more, okay? So this is abnormalities of motion of the eyes, okay? And that can denote that there's some kind of reciprocal neurologic impingement, which takes it in a whole other different direction. But what are we getting at here? We're getting at here that if you look, we're just going to skip spine for a second. if you look at it, it can be caused by trauma. There it is again. So can it be childbirth? Yeah, it could be childbirth, right? So the traumatic experience of childbirth, not just the mom, but the child, okay? So infection, there we go. And neoplasms, tumors, bad things, okay? And again, just because somebody has a tumor, does it necessarily mean it's malignant? It could be benign, right? But these are things that were formed in the shoot, right? You guys have heard me say it before, right? Prior to delivery, potentially. So it's, again, this is something that could have grown over time is what I'm saying, okay? Now, getting back to the spine, we already know what atlantoaxial, right, is, right? Atlantoaxial, but this is something very specific, ARDS, A-A-R-D, atlantoaxial rotary, or rotational displacement, okay? So because there's abnormalities in or around the atlantoaxial skeleton, right, or vertebral column, then the patient has displacement and abnormal rotation of the neck. Okay, so you can see why, again, if there's abnormalities in the spine, or the bones, if you will, then the neck can rest in a certain position. Make sense? So that's why this does not necessarily have to do with contraction of muscles. Okay? Initially, but then over time, if the child, right, the patient is stuck in that position where they get contractures, yes, those can develop. That's all they're saying there. Bless you. Oh, all right. So congenital cervical spine anomalies, again, this doesn't tend to be the atlantoaxial rotation specifically. This is just all comers. Right? You gotta have a category for everything else, right? So that's any abnormality in the cervical spine, basically. But that causes things like progressive congenital scoliosis at the cervical-thoracic junction. So again, remember, when it comes to, and this is why it gets confusing in that terminology, right? We're talking about acquired, right? But they still came out with certain congenital abnormalities. They just didn't manifest themselves until later in infancy or in childhood. Make sense? CMT is exclusively in and around the time of delivery, right? Somebody asked me last semester, I looked it up. I said 3 or 4 months, I was right. By the literature, it states that a high percentage of cases of CMT are found and diagnosed in the first 3 or 4 months of life. Just to make things complicated though, does every patient, all around the world get routine, medical care? No. So I'm not trying to teach you wrong. You need to look for it, okay? All right? This was present since birth. Aha! This is maybe more so CMT, okay? That just was underdiagnosed, right? Undiagnosed, however you want to look at it, okay? Any questions about that? I know that terminology is really confusing because they use the same, it's like using the word to define a word, right? It's very confusing. Just don't get those things confused, right? When you're doing a PANCE question, look at the age, look at the presentation, look at any other associated factors, and that'll lead you down a certain path, okay? All right, so I added this picture too because, of course, just like the waiter tit position, you can probably look in there online, you'll see a bunch of different terms. So that position of the head, whether it's the tilt or the rotation, is also called the cock-robin appearance. Okay? That's AKA, head tilted towards the affected muscle. Okay? Tilted, not turned. Know your terminology. It's turned away from the affected muscle, correct? Sir, do you agree? Yes. Okay. All right. Sorry, I didn't mean to wake you up. But I'm joking. Yeah, sort of. So when we're talking about CMT, again, that's that cock-robin position. So don't let that throw you off. Get that term in your mind, right? Get the words in your mind. Is there different ways of saying this? There is, right? But on PANCE, look for the rotation versus the tilt. If you do that, I think you'll be fine. Good to go? Okay. All right. So acquired ARDS, right? Acquired atlantoaxial rotary displacement, right? That's going to be tilt the same, but spasms on the opposite side. Okay? This is talking about the tilt, not the rotation. Rotation could be a mixed bag. Okay? Is that abnormal? Does that go against that cock-robin? Yes. Take a minute when you're studying later on. Get in your head. If you have to, look up more examples, okay? Get in your mind though, right? I'll see some of you guys doing the whatever thing during the test, all right? Some people get that spasmodic torticollis when they get nervous. Your neck kind of feels like it's locking up, right? That is not what we're talking about here, okay? This has a very specific rotation and tilt. So is a complete neurologic assessment important? Absolutely 100%. We already talked about how there could be eye involvement, right? So a complete ophthalmologic exam is important as well. Are you able to do that in your clinic for a neonate? No. You can't talk to me after class. We'll talk about it properly. Right? That's difficult, right? So, yeah. Complete musculoskeletal exam, well, that's could be anything. Is it important to do a head to toe? 100%. Might you get a baby gram? Yes, 100%. Might you get advanced imaging? 100%. But your MSK exam should be on point, okay? Make sure everything's moving like it should. Can you have this condition and also have Ehlers palsy? You could, right? But that's something you don't want to miss, okay? Makes sense? Developmental dysplasia of the hip. We will talk about DDH more so with next block. But DDH, or developmental dysplasia of the hip, right? DDH, is basically an abnormal formation of the components of the hip joint. Okay, and there's differences there. We'll talk about that more again next block. But if they already have congenital abnormalities when it comes to their neck development of their C-spine, right, and or musculature, might they also have what's called packaging abnormalities? So things come in a package. You get a little bit of this, you get a little bit of that, right? So it's just saying that it could also be associated with DDH. So do you think if we see somebody with a cock robin appearance, we might get, again, that babygram, just to get a general sense of what the hips look like, or maybe get dedicated hip views if there's a concern? Yes, but more importantly, we're going to do a complete range of motion of the baby, right, and make sure the hips move. We'll talk about a baby exam as we talk about hip stuff too, okay? I'm trying to order like a $2,500 mannequin. They told me good luck, right? But we'll figure it out. So intrauterine deformation, that's such a broad category. That could actually be something that's like they were given a medication and it had effects, right? Or the development was affected because of a period of time when the patient sustained a brief period of decreased oxygen intake, right? Decreased ventilation. Maybe they were sustaining an injury, right, at altitude or something. I don't know, something crazy. So that's such a wide, broad category. Just understand, again, things come in certain subsets, okay? Any questions about the cock robin appearance? That helped me. So, all right, so you guys see the arrow there? Does that look like it should look? No. Am I going to give you a bunch of radiographs of C-spine of neonates? 100% no. All right, there's no value there. I just want to get you guys to understand, like, why are you getting this imaging, right? You may literally, this is a CT scan, okay? Well, you may literally get an X-ray and you're like, whoa, that doesn't look right. So then it needs you to get more imaging, right? Because if you don't understand what's causing that atlantoaxial rotation, because it says all acquired torticollis, correct? So that's the arch, right? And other things, okay? If you don't understand what's causing that rotation, you don't know how to treat it necessarily, right? Good to go? Does that make sense? Do we always get x-rays for CMT? Depends on the provider, okay? I teach you guys to always get imaging, right? Because I think you miss less that way, and you're not worried about that little bit of radiation. You're worried about that a lot of bit of badness, okay? Make sense? But you must, if it's acquired. You have to get x-rays for all cases of acquired torticollis, okay? Because you're trying to rule out those congenital bony abnormalities, which can live in a bunch of different areas, right? Because I talked about the cervical-thoracic junction, correct? So if it's a cervical-thoracic junction, do you think you might also get thoracic views? Yes, right? You want to get everything. So it becomes a little more complicated there, okay? Any questions about these pictures? This is, again, just for your enrichment or your knowledge. Just understand that, you can see certain abnormalities, okay? book doesn't go into it too much. So MRIs, I mean, if you guys don't understand, when you have neurologic symptoms, you gotta get an MRI by now. I don't know what to tell you, but if you have concerns about neurologic deficits, right, because the patient's not gonna be able to tell you necessarily, right, in acquired maybe, right? But if you're worried about it younger, maybe they can't tell you things, okay? I already told you that sometimes the acquired torticollis goes with certain other conditions, correct? Do you think that it might be some other conditions where the patient has poor verbal skills? Yes, right? So it can be challenging, okay? Makes sense? Everybody knows what I mean by poor verbal skills, right? So, okay. Syndromes, you guys probably learned a bunch of syndromes yet, right? You memorized the 2 or 3 characteristics of it, and that was good. Don't worry, you'll get deeper into it, okay? Especially in endo, you're gonna love it. All right, so, but again, going back to congenital, most of this resolves. What percentage? 90%. There's 10% of patients that don't improve with time. 10%. So a rule is improvement. Like I told you guys before, do you have to tell the parents that? Please do, right? Don't get a bunch of email traffic later on. Just get into it and explain to them, hey, your son, daughter, has congenital muscular torticollis. The literature states, this is what you say. Right? You guys are writing your papers, right? So the literature states that 90% of patients improve with only conservative care. That sounds powerful, doesn't it? The literature states. You guys already know. It may only be one study with 4 people, but the literature states it. Right? So work it. All right? There you go. I've read some of your papers. All right, so acquired depends on the underlying etiology. I don't even go into it. I am not going to test you on all those underlying etiologies. I will tell you, here we go, somebody just woke up. No ARDS, right? Know how it's different than CMT, right? But I will not test you on every little thing that could be on an x-ray. I just won't, it's just too much, right? Do I even know all of it? I don't know if I remember all of it, right? There's a bunch of craziness out there, okay? So, but operative, does CMT get surgery? No. So if you see a question about therapy and or if there's an operative indication, all acquired will go on to get surgery if something is found that needs to be corrected. Does that make sense? Okay. But if it's congenital and it's been longer than 12 to 18 months and they don't improve with the stretching program, right? You can't tell a patient that age to do the exercises, right? So like it's demonstrating in this picture here, right? That pediatric physical therapist and the parents will be performing this. They will get education on doing this at home. Make sense? So I will tell you this. How do you verify that the patient's parents are actually doing the exercises? Demonstrate it. Show me the exercises you're doing. Again, I hate to I tell you this, I'm an ER guy, ortho. We have a saying, all patients lie, right? And their parents lie twice, okay? But I will tell you that it may not just be that they're not doing it, they may just not be doing it correctly. Or they feel like they're going to hurt the patient, right? So you gotta teach them, like, it's okay to be not aggressive, right? We use that term in ortho, aggressive, with speed and intensity, right? But it's not aggression, right? It's just the appropriate amount of technique. Therefore, you're not putting the patient at risk for other injuries, okay? Make sense? Any questions about these pictures? I will not be asking you what are the exercises, describe them to me, tell me how many times a day, things like that. I just wanted you to have an example that, hey, it's important to understand how the patient's parents doing them correctly. How long has it been? When do I think I should refer this patient? Okay. Because do you think if the neck is stuck in this cock-robin position for long enough, that then they have to go in there and do releases? Right? For sure. If they're getting no slow and steady return of motion, just like we talked about in adhesive capsulitis, but over time they're improving it, even if it's gradual. If these patients are getting no improvement over time, then they're going to get those contractures, and they may need more heroic efforts, surgery, to release those contractures. We don't want to get to that point. So how many months is it again? 12 to 18 months. Perfect. Okay? There we go. There it is. We summed it up. I don't have to say it again. Any patient with head-tail rotation to the same side, well, that doesn't sound like cock-robin, does it? That sounds weird. Okay? So again, atlanto-axial rotation can cause all kinds of funky presentations. Don't get focused on that. Just understand that the cock-robin position, that's CMT, and everything else is something else. So it's acquired. If it's due to atlanto-axial rotation, displacement, rotary displacement, excuse me, then that's why it's called ART. And it's a very specific one. But everything else can be kind of a mixed bag. Okay? There you go. All right. This is what we talked about, rupture of the proximal biceps tendon. I think it's important to understand that we talked about rupture of the proximal biceps tendon when we were talking about shoulder stuff, correct? That makes sense, doesn't it? Because it goes into the shoulder joint. So when we talk about distal bicep ruptures, we're going to be talking about elbow stuff. Because doesn't the distal biceps insert distal to the elbow joint? Huh, that makes sense, right? So, you know, a little bit of gamesmanship when it comes to reading the question thoroughly, okay? Shoulder instability, you're just gonna have to take time with that. I wish I could lecture on it for hours, but we can't, right? I gotta give it to you, you gotta go back, you gotta look at it, see if you understand. If you don't understand, ask questions. I would lean, flush again. But I would lean towards going back and reading the highlighted reading, okay? If you have, especially if you have significant questions, I just don't get it, because maybe that'll explain a little bit better. And then by the time we do our test review, then you'll ask a question I can actually answer. All right, let's be focused, right? Don't just be like, hey, can you go through that entire lecture again? The answer's no. At least not in this setting. We go in my office and do one-on-one, that's fine. But we gotta keep moving, okay? Shoulder instability is difficult and challenging if you don't understand the terminology, because there's radiographs involved in it too. Slap lesions, whew, I actually went a little bit off track a little bit, right? But it's partly porous because we talked about elongating of the biceps. But I explained to you how a lot of times you're going to say that the patient has a slap lesion, and then this gentleman may say, well, the patient has a biceps tendonitis. Who's wrong? Sometimes neither one of you are wrong. They can have both at the same time. Make sense? Absolutely. So it's important to understand that slap lesions, yes, are very specific advanced imaging findings and things we see on arthroscopy, but the symptomology can be very, very similar. So go back, start laying things on top of each other again, and see how those tests, the special tests, right, can be different for different presentations and different pathologies. Make sense? Okay. Look like I'm being handcuffed. So thoracic outlet syndrome, there you go. You got plexopathies, both brachial plexopathy versus neonatal. Now you got that, right? You got TOS, right? And then you got neonatal. God help you if you say TOS for a neonatal. I'll be sad. All right, so understand that those are in different patient populations, okay? And then torticollis, is there certain neurological involvement with it? Maybe, but it's a very specific presentation for CMT, and there's a history that comes with it. That cock-robin position, you should know that inside and out. Good to go? Okay. We're going to keep moving. Questions? Question mark? Elbow pathology. This should be a little bit faster because you guys already covered a little bit of the condylitis, right? Olecranon bursitis. Everybody knows where the tip of your elbow is, right? It's where your powerhouse move is, your WWE, jumping off the corner, you know, landing, right, on that brachial plexus, right? Olecranon bursitis is something that you don't want to play with, and I'll teach you the kind of a mindset for that. We're going to talk about nerve compression syndromes. This is where people go full tilt. Because you're like, wait, oh my God, nerve compression syndromes. Right? Again, I keep telling you guys, I've prepared you for this topic. It can be the neck, the shoulder, the elbow, the wrist, oh, and guess what? The hand. Right? Where's that compression occurring? All we're getting at with nerve compression syndromes here is we're talking about elbow stuff. Okay? Don't get lost in the sauce, as they say. Okay, distal biceps tendon rupture, we just went through. UCL tears, okay? I added that. That's of the elbow. You saw that on your sheet. We're talking about UCL injuries of the thumb. We'll talk about that in lab. It's actually not part of the core course requirement, so I'm not sure why it's in there. We'll talk about that. But UCL of the elbow is, you need to know UCL of the elbow, injuries, pathologies, treatments, diagnostics, etc. Okay? There you go. Okay. Nurse-maid's elbow, we'll talk about what that is and how adults don't get that. All right? And little leaguer's elbow. If we get there today, fine. Little leaguer's elbow, I hate that term. And you will too. Because it doesn't capture everything. what's the age for Little League? Who's a baseball player? What's that? 6 to 12? Okay, okay. But you would agree that anyone under 18 is not an adult, correct? So that's what's frustrating. You got about 4 years there where you can have pathology, and then guess what? If it's not one of the other conditions, then it's just a UCL tear, right? So then it becomes confusing. I'll try to go through that slowly. Like I said, if we don't get to it today, it's A, because I passed out, or B, because I felt like this is too much. We need to spend some time with that tomorrow. Okay? Good to go? All right, epicondylitis, inflammation on the epicondyle. Okay, everybody, tell me, when you are on your lateral elbow, right, is that the extensors or the flexors that insert there? Extensors, that's the common extensor, right? Common extensor region, okay? So, extensor carpi radialis, right? ECRB. All right, at this stage in your careers, you should not just be using acronyms, okay? All right, you'll sound smarter in phase 2 if you say extensor carpi radialis brevis. Okay, that's what we're focusing in on when we're talking about lateral epicondylitis. Yes, you use terminology like tennis elbow. You'll never see me use that with you if you come with me to phase 2, because then I want you to tell me what is involved, right? Okay, good to go? So understand your pathology. All right, so do you think that when we're doing certain tests, we're testing extension of, let's say, a finger against resistance and seeing if they have pain at the lateral elbow? Yes, because that's the site where they normally have epicondylitis, otherwise known as lateral epicondylitis. So break those two things out, okay? So then if it's medial epicondyle, would you agree that that's where the flexors go? Okay, so again, when you're doing testing, you're testing the flexors against resistance. Okay, we'll get there. Lateral epicondylitis, 30 to 50 years old. I'm going to put myself in that category, even though it's a lie. Right? But it's people that maybe are a little bit older, right? Or maybe not at the flexibility that they once used to be, or overuse. Overuse happens at all ages, correct? Okay. Most common epicondylitis. Most common. Lateral is the most common. Gradual ossitive pain, lateral elbow. Okay. Again, don't fall for that pants trick where they tell you it's elbow pain, and then you never really figure out if it's medial or lateral, because that's important. We'll talk about one distinction. Okay. So gripping and wrist extension activity. So that's what they're going to tell you. You know, who plays tennis or pickleball? I guess that's a cool hit thing now. Nobody wants to admit it. Okay. But tennis, more like this, correct? Extensor. All right. They're not talking about this. They're talking about this. Okay. So extensing. All right. So any activity that kind of recreates that. What are the things that do that? Lifting, especially if you're doing it poorly or too heavy. Marine Corps. Turning a screwdriver, right? And again, that's that tennis backstroke. So those are the kind of activities I'm going to describe. So when you're reading this scenario, they may not give it to you, but they may give you the activity. Okay, and then you're like, huh, I got this. This is the extensor side. This is lateral epicondylitis. Nailed it. Okay. All right. So pain with resisted extension. Huh. That's what I was just talking about. This is why we're going to go quickly here. So if you understand your anatomy, I keep telling you guys this, right? And Mr. Livingston agrees with me. If you know your anatomy, you are a powerful clinician because you understand why things are happening, right? You understand why you should be concerned about pathology. Where's the tenderness? You need to know this. Memorize it. Is it necessarily 100% like this every single freaking time? No, but according to the textbook, it is lateral and up to 1 centimeter distal to the joint. So it doesn't necessarily have to be right on the epicondyle, okay, the lateral epicondyle specifically, right? It can be a little further out, but no greater than 1 centimeter. Because if you're going greater than 1 centimeter, there's a whole other condition that could be occurring. More in the middle muscle bellies, right about the mid-forearm. Right? You guys would agree where my fingers are now is definitely more than 1 centimeter. You know how to find 1 centimeter if you didn't before. That's the width of your small finger. Right? That's 1 centimeter. So go up. Okay? All right, so resisted extension. Okay? A lot of times there's an argument here. So I always do it with the elbow bent, so I isolate the motion. But they say that the book says you're actually supposed to do it with the elbows and extension. You guys decide what you think is better. I just know how I do it, okay? But I won't throw you off on that on the test, okay? All right, medial condylitis. Switch your brain. This is all medial, right? So these are not extensors, these are flexors, okay? So medial epicondyle, golfer's elbow, right? Tendinitis. It's also known as bowler's elbow. I always forget that it was called that. I guess it's because of this. All right, how many bowlers do we have? Yeah, okay, thank you for being, well, you might be lying, but thank you for playing, at least. So when you bowl, do you get this?
Yeah.
You do, right? So it's actually not uncommon. It's more common in bowlers, believe it or not, than it is in golfing. All right, so maybe that's what we should be calling it primarily. But either way, so when you get a clinical vignette, mind to tell you that the patient is an avid bowler, right? Right. Okay. He's gonna nail it, right? But it's that common tendinous origin of the flexor, focus on the flexor, and pronator. We know what pronation is, right? Pronation versus supination. So that's the pronator origin as well. Okay, so you can't, you gotta know your anatomy. Okay, but primarily, the patients have pain with activities that cause them to do flexion. Less common than lateral. Okay, less common than lateral. Okay, wrist flexion and forearm pronation. That's going to be that position. Glove swing, baseball, pitching, bowling, and weightlifting. Weightlifting can cause pain everywhere. All the itises, all the tendinitis, right? So, okay. So, you see how? What, do you think if you have somebody flex, especially if you put your hand here against resistance, right? Hand here, right? In this distal aspect, and you have them flex against resistance, that they're going to report pain on the medial aspect of their elbow? Yes. Okay. And again, it's still acceptable. You're at the elbow. It's still acceptable to use medial and lateral. If you go up distal to the elbow, start using ulnar radial. Otherwise, you'll get tripped up. Okay. Medial and distal to the medial epicondyle. Okay. So, why would you get X-rays for epicondylitis? It's muscles, it's tendons, it's insertions. Can you get this here? If it's been pulling long enough, you might actually pull a little piece of that tendon as it inserts there, right? And it can calcify. Okay. So if you see that, maybe the management is different, correct? You might also be looking for fractures. Okay. Does everybody see that very fine little area there where there's that the ding, if you will, that little chiclet kind of floating in that space? Okay, that may be an indication that you need to get an MRI, especially if you have certain physical exam findings that we'll talk about. Okay? So rarely calcification may be seen. Okay? I will tell you this, that we say that OA of the elbow is common or uncommon? Uncommon, correct? Unless RA. Correct? But that's not osteoarthritis, that's rheumatoid arthritis. Totally different condition. You guys are becoming smarter. Some of you guys already knew this, right? But just understand that when we're getting elbow x-rays, we're actually looking for not OA, but other bony abnormalities. Good to go? Because if you miss those, you might be treating it wrong. If you just say, oh, it's probably just OA of the elbow, first of all, you're going to make me sad, right? Because I'm still going to tell you, hey, get x-rays, bro. Or ma'am, right? Because I don't know about you, but my x-ray vision sucks, right? So then you get the x-ray and you see the chiclet, and you're like, oh, this patient may need more than just therapy at some point, okay? But if there's a question about it, MRI, okay? Persistent pain, weakness, inability to participate in sports. Are you going to tell the patients to stop doing tennis, stop doing bowling? Sorry, sir. If you came to me with bowling elbow, I would tell you, as sad as it's going to make you, you need to stop for at least 4 to 6 weeks, okay? I tell people there's a rule, okay? There's a rule. If you've had pain for a month, do you think if you rest for a month, it's going to go away 100%? This is where it's not yes. The answer is always yes, except when it's no. In this case, it's no. Okay? It's a ratio. Right? There's no exact number, but I'm saying if you've had really bad, intense pain for a month, right, on top of chronic medial elbow pain, I tell them it could take you a month. It could take you 6 months. It could take you a year. Right? Don't lie to your patients and set appropriate expectations. Okay? If they have a rupture of the flexor pronator or extensor mass, okay, so that's, extensor mass, again, we're talking about lateral epicondylitis, right? Okay, medial epicondylitis, we're talking about the flexor pronator, okay, mass. If you have a rupture there, all bets are off. You can't rehab that. You gotta fix that. Okay? There it is. What percentage, right? I changed the slide, allegedly. So what percentage of people improve with just conservative care? In the terms of lateral epicondylitis, it's 95%. In the terms of medial epicondylitis, it's 85%. Right? Read it? Yeah, yes, that's what it says. All right, good. So you would agree that that's a high percentage of people that are going to improve with conservative care. But is it going to be a month of physical therapy? Or might you see them back? Remember I told you about Ambry, right? Might you see them back and you're like, you made some improvement. But I suggest you can continue going. Okay? Or if they're given a home exercise program, and we've talked about the difference between formal physical therapy and a home exercise program, right? If they're given a program and they're more seasoned, right? I like to think of myself as seasoned, right? Might you tell them, hey, you're gonna have to do these the rest of your life, especially depending on how much you golf, how much you bowl, how much you like to turn a screwdriver, etc. So it may be a lifelong change in their lifestyle. Corticosteroid injection of symptoms persist. Focus in on me real quick, okay? No matter what you're doing right now, understand this. The only role for corticosteroid injections is lateral epicondylitis. That's the only place it plays a role, as I should say. Medial epicondylitis, where does the ulnar nerve sit? Medial or lateral? Medial. Everybody knows where the funny bone is, right? Not so funny. You go sticking you go sticking a needle in and around the ulnar nerve, that's going to be a bad day for your patient and not a good thing for you as a provider. There is no role, okay, for corticosteroid injections in medial epicondylitis. So if you know for a fact that Pant's question is referring to medial epicondylitis, and you see an answer that is corticosteroid injection, you know that's the wrong answer, correct? Because, for the reasons I just told you, you don't go sticking a nerve in and around that area. We talked earlier about the ulnar nerve is important, right? You don't want to bag the ulnar nerve by sticking a freaking needle into it. Okay? That's a bad day. Okay? There you go. All right, good. Non-operative treatment failure is really the indication for this. All right? Rare that there's surgery for this. I've actually been involved with a few of them, but do you think that those patients had a history of, I went to see my provider, they gave me physical therapy, plus or minus an injection if it was lateral epicondylitis. I got better. I went back to see my provider because it started hurting again. They did another injection. They got better. Now I got same symptoms. I went back to them. They did an injection. I got a little bit of relief. You see where I'm going with this. There's a history behind it, right? They've been doing that in non-operative care before you send them to a surgical person, right? Because all they're going to ask them is, have you done any of these things? No. Go back to your PCM, do all that, right? Because surgery for this is not common and not, I'll go ahead and say it, not definitive. Debridement. What is, I already taught you what the term debridement means, right? You go in there and start mucking things up a little bit, go in there and start whacking things. You're like, that doesn't look normal. Does it not though? Like, maybe it is, I don't know. You go start pulling chiclets out, right? If you see a big chiclet and the patient's having snapping and cracking of their elbow, maybe that'll give them some relief. But if you don't really see anything on imaging and you go in there and just start mucking things up, otherwise known as a debridement, are the patients going to get 100% pain relief? No, right? So again, like I told you before, be tapered in your education. Don't tell them you're going to go to ortho and they're going to get 100% pain relief. I will find you. I promise. Okay. What is this strap here? I need to talk to you about this. You need to know this term. Okay. This is a strap. Okay. And what this strap does, you understand that right at the lateral epicondyle. I'll use lateral epicondylitis as an example. That's where the origin of the extensor mass is, right? That ECRB, okay? So that length runs from your elbow, where I'm pointing right now, all the way down, right? Does it cross your wrist? Yes, right? Now, if you put a strap between those 2 points, right? Do you change the working length of that tendon, or the muscle belly, excuse me, and therefore the tendon? You do. You change that working length. You change that lever arm. Okay? So that can cause patients to have a decrease in their pain because they're having less tension on that working arm, if you will, that length. Make sense? So this is an elbow strap, okay? There's a bunch of fancy terms for it. I actually have lateral epicondylitis when I was actually physically active. I had it all the time, so I have one of those. They work. Does it work for everybody? No. But I just explained to you why you need to try that. And by the way, without any test compromise, you may see that on pants. Okay? So I was just like, huh, that's an interesting question to ask, especially to an ortho guy. I'm like, because I tell people you can use those, but not everybody gets the same response from them. But that's an idea. Okay? Do you sometimes see something that looks very similar for runner's knee? The patellar tendon strap, same concept, different body part. Correct? Makes sense? Okay. Adverse outcomes, you know about the NSAID stuff. Multiple steroid injections, even for lateral epicondylitis, because that's what we're talking about, right? If you inject them long enough, you know how we tell them they're going to have skin changes. They may have some atrophy of the muscles. You guys feel that lateral epicondyle? Is that pretty superficial? Yes. So I will tell you, when it comes to that atrophy and those skin changes, okay, I very commonly see that for corticosteroid injections for lateral epicondylitis. That's one of the more common ones. Okay. That and carpal tunnel. Carpal tunnel is usually someone did it wrong. But lateral epicondylitis, even with the best efforts, you can sometimes be too shallow, and you can get those changes that we always counsel patients on, right? Incomplete pain relief despite adequate surgical release. I don't know what the term adequate means. They're just not trying to offend us, right? But we don't know. I don't know what adequate is. Again, we go in there sometimes we just start mucking things up. Red flag. It says suspected nerve injury. Are we going to talk about nerve compression syndromes soon? Yes. So if you think you have a little bit of epicondylitis, but a lot of, or even a little bit, of entrapment of the nerve in the elbow, right, then you need to refer them. Okay. I want to get through olecranon bursitis. Are you guys cool? Push for a little bit. All right, give me a few mics, and we'll move on, okay? I want to get to at least this. So olecranon bursitis. So everybody knows where your olecranon is, right? We did our review. I will tell you this. I'm not even going to put the slide up. Okay. All right, so that bursa is between the bone and the skin, correct? And the open environment? Okay. So that's the bursa. Where's the joint? The joint is here, okay? Now, if you do bag technique, can you put a needle through the bursa and end up in the joint? Yes, you can. And very easily and very quickly. Just feel the difference. Put your finger on your thumb, right? Put your finger, right, your index finger on your lateral epicondyle, and put your thumb on the radial head. That's not a huge distance to travel, okay? And just because you're traveling from the posterior aspect doesn't mean you're not going obliquely, and you can end up in the joint. Make sense? Okay? So what I would tell you is, don't be that person. Don't be the person that takes olecranon bursitis and makes it septic arthritis of the elbow. Don't be that person. Okay? I'll tell you my story here in a minute, and you'll be like, nah, that never happens. It happens. People go. The history is multiple bursitises, right? Because we know what bursitis is. Irritation and inflammation of the bursa. In this case, the olecranon bursa, right? And what can cause it? Fall or direct blow. Okay? So that's acute, right? So fall, direct blow. So do you think people that get into certain firing positions, they're on their elbows a lot, they're doing low crawls, things like that? Seen it from that too. You know, open abrasions. Q courses, pipeline guys, you know, I've seen this. Okay, very not uncommon. Okay? Excessive propping. If somebody's a truck driver, did anybody here used to drive a truck? You did? Okay. Long distance? Not long distance? Just a Circle K? I'm going to use it as my guy. Okay? I got some stuff about that. All right. So when it comes to chronic, it's leaning, right? So somebody's sitting there with their elbow leaning up against like the side, right? The door side, with that little prop to rest, or the center console propping and resting. Okay? Makes sense? Okay. So that's the propping. All right, so you can't miss the fact that it can be RA. RA is all over the place, right? Can it be gout? Yes. What is chondrocalcinosis again? Hopefully we didn't forget. What is it? Pseudogout, right? Chondrocalcinosis. Can it be that? Sure. Okay. Okay. All right. So let's not forget that. Okay. Does that look like you should be worried about infection? Yes. Chunky monkey, right? That looks like either larva is erupting from there, or that's the head of pus, right? That's a nice little tip of pus, if you will, right? When I was rotating the ER and they had something like this come up, the nurse would yell, pus, PA student. You know, basically anywhere I was, I knew that there was pus in play, and that I had to come and deal with this. Right? PA student's job was the pus. They said that's what the P stood for in PA student. Right? So, but understand that you need to ask them about a history. Right? Is there a history of poke holes? Hopefully, again, ID is teaching you guys to be paranoid. Do you have a history of travel? Do you have a history of any poke holes there? Any kind of trauma? Any kind of injury? Let's say it healed over and now it opened up. Make sense? Okay, so you're looking for acute versus chronic etiology. Okay? Get a good history. Okay? Pain can be variable, especially if it's small, right? And we'll talk about that. Limited elbow range of motion after acute injury. Well, obviously, if it's a big old swollen elbow, there's some pictures coming up. I think you'll be able to move it, and especially without pain. No. Okay? All right? Firm lumps. Okay? Just because there's pus in there, does that mean it's ooey and gooey? Or can it consolidate? We know what lung consolidations are, right? So we can get pockets of pus that harden, that dry, and it's inside of there. There's a liquid component to it, but there's also a hard component. So you may actually feel firm lumps, right? Gouty tophi, and RA nodules. We already talked to you about those, right? Are the RA nodules painful or painless? Painless, right? All right? Okay, so kind of put it all together, right? Much harder than scar tissue, okay? So just because somebody had a history of like repetitive trauma to that area, now you got an area that's not necessarily, doesn't feel like a scar. It feels like chunks of something that may be more deeper underneath, okay? So, ooh, look at that elbow. So this is how it started, right? And then you end up with that. Do you think that's painful? Do you think that patient's holding your elbow in flexion because they want to necessarily? No, that's the position of comfort, if you will. So when you get into trying to extend, you have that term, exquisite tenderness with attempted range of motion. I'm telling you what the chart does. Okay? Large mass, up to 6 centimeters. You already know how to find one, so you find 6. Okay? And you're like, okay, 6 centimeters. Do you think 6 centimeters might be something that needs surgical evaluation? I told you guys the difference between surgical evaluation and surgical treatment, even in the surgical realm. Just because we see them doesn't mean they're going to get surgery. It just means that the surgical evaluation is being done by us now. Okay? Septic, red, hot, swollen joint. I got away from the edema, erythema, ecchymosis. I'm just telling you, red, hot, swollen joint, elbow with a history of previous bursitis or some kind of penetrating trauma, some kind of penetrating wound, or some history of chronic wound that kind of opens up, closes, opens, closes. Okay? That's what that yellow term is getting at there, the bold gold, excuse me. Okay? If it's recurrent, it says they're usually less tender. Sure. But you need to know if it's serious, right? All right, so can you see the swelling on this radiograph, guys? Yes. Would you agree that the imaging you're going to get, because you're going to rule out fracture or trauma or any kind of penetrating injuries, can you see free air in the elbow if there's a tract that's going into the elbow joint? You guys learned about free air, right, on radiographs in radiology? So the answer is yes, okay? So, but you want to rule out fractures, right? And you can see the soft tissue swelling, like I said. Do you see this angle that this provider is taking to be very shallow, to not go into the freaking joint, right? Burn this in your mind, okay? Because this is, if you're going to do it, you recognize that the bursa is very superficial compared to the elbow joint. So this is the approach you're going to take, okay? I had a patient came to see us because they were septic. The ER called us. We took him immediately. We zippered him. We went from his posterior shoulder all the way down a little bit distal to the wrist. We opened all that up, right? He never regained consciousness after we got out of the OR. He had necrotizing fasciitis. Going back into history, Okay? Applied surgeon had seen him, I won't use names, and done 3 aspirations. 3. And the patient was complaining of increasing pain, red hot swelling. Does infection sometimes peer its head and then kind of pull back a little bit, go back in shadows? It does, right? So the fevers kind of come and go, and then are gone for a little bit. But the clinical picture was red hot swollen joint at times, and a history of multiple traumatic pokes, right? This, like I said, we washed that dude out multiple times. I did a running interlock suture to close his zipper, essentially. Everybody knows what I mean by zipper, right? Just a big incision all the way down. Right? I did a running interlocking, ran it back to the tripler. I don't think he's living. I don't know, but I'm just saying. So it started with good intentions, and it ended up in bad outcomes. Okay? This was a United States Marine on active duty, living in the barracks. His staph aureus all over the freaking barracks. It is everywhere. It is everywhere. If you don't think it's everywhere, yeah, it's everywhere. All right, so aspiration. So if you look at this swelling here, right, that's painful, right? I don't think in that swelling I would do an aspiration for comfort measures, but would I consider doing an aspiration for diagnostic purposes? Yes, okay? So that's all they're getting at there, all right? Large symptomatic masses, okay? Analyzed for white blood cells, crystals, gram stains, and GAN cultures. This is what's been happening. This is the bad stuff. Again, remember I told you that wound, it kind of opens up, closes, doesn't really go away. Gets a little more swollen at times when they don't rest their elbows as much or they're not firing off the line as much. It's not symptomatic, but then it just never quite goes away, and it drains every once in a while. That's what they're talking about, chronic draining wound. Secondary infection, that's what I just described to you. Okay? Maybe that MRSA was infected, but who cares? Somebody took the MRSA and went all the way through. Right? Yeah, that wasn't a good day. Okay? Learn this chart, okay? I don't want to read it to you, but just understand the difference between a small, mild symptoms and a large symptomatic bursa. Right? Large symptomatic bursa is that you think that's something you may consider draining. Yes, as long as you don't think it's infected, correct? But if it's small, the rule is if they're small, and especially if they're mildly symptomatic or not symptomatic, don't go sticking needles in places you're not invited. There's no therapeutic or diagnostic value in that. That's why we always talk about the risk versus the benefits. Okay? That'll keep you out of badness. Okay? Septic, again, it says IV antibiotics there. So is this patient going to be hospitalized? Yes. And they're going to be following on the floor. Okay? Operative, do we do sometimes bursa excisions for people that go on to have these chronic, especially if they're chronic open draining wounds? Sometimes, okay, in the right patients. Okay? You see how it talks here about elbow pads and compressive wraps? That's this, but it can also be ACE wraps, right? If you have compression, isn't the C compression, right? That's the C in rice, correct? So we're not talking about any mind-boggling things. Treatment, you can do treatment. They can still chronically recur, right? This is somebody that went through. This is an example of a chronic draining wound, right? Looks like it just looks kind of ooey and gooey, right? So they went through and they tried to do a skin graft there, and that doesn't look good, does it? Because the skin is intact now; it's closed over, but they still have swelling there. You guys see the swelling, right? So that just looks like somebody took, I don't want to be vulgar, but we take skin from buttocks and put them on other places of the body, right? So, yeah, so it looks like a swollen butt. And it may actually be, right? Maybe buttock tissue. Okay, makes sense? All right, red flags. It says recurrence after multiple aspirations. Okay, fine. Learn what the book tells you guys. When you're out there in practice, if you feel like you're going to do badness, call somebody. Good to go? Okay. Please. Hey, perfect. Good stopping point. Thank you. Have a good rest of your day.